of this land. We would like to begin by acknowledging that the land on which we gather is a traditional territory of the Wendat, Anishinaabe, Haudenosaunee, Métis, and the Mississauga of the Scugog, Hiawatha, and Alderville First Nation. Purpose and learning outcomes. This presentation is meant for general public, social work students, job aspirants of hospital social work. Hospital social work is a large and complex area of social work practice. Please note that this session is only presents an overview of hospital social work practice in Ontario. Learning outcomes. An overview social workers' roles and practices in various units and specialty areas in hospitals. Understanding the knowledge, skills, and qualifications for a hospital social worker. The speakers will complete the specific areas assigned to them one after another, and we will have a question and answer session at the end of the presentation. You are encouraged to post your questions in the chat box during the presentation, and we will take up those questions to the appropriate person in the panel of response. The topics covered: legislations pertaining to hospital social work, settings of hospital social work, role of hospital social workers, psychosocial assessment, interdisciplinary approach, discharge planning, crisis situations, and education and research. About our speakers. Friends, it's indeed a great privilege for me to introduce our panel of speakers today. All of them have decades of experience in hospital social work. The practice of hospital social work varies from hospital to hospital at the micro level within the larger framework of hospital social work. Today, each speaker will be talking about different areas of hospital social work in the light of their department's specific experience. All of them played a vital role in mobilizing Malayali social workers across Ontario in the early days of MASWO, and tremendously helped us for our professional and social integration. Firstly, I would like to introduce Mr. Joseph Kalath, one of the senior most social worker from our community. Mr. Kalath has over 30 years experience in social work. He obtained his master's degree in social work from Loyola College Madras and University of Toronto. He started his social work career in Canada, in child welfare, and eventually moved to the hospital setting. Can you mute the mic, please? Over the years, Mr. Kalath worked in psychiatric and medical units in different hospitals in GTA and retired from Toronto General Hospital. Mr. Kalath played a vital role in setting up the prestigious internationally educated social workers bridging program at Ryerson University and served as a teacher for 5 years in that program. Mr. Kalath's extensive experience is mainly related to emergency departments in hospital setting. He has actively involved in mentoring new social workers and conducting social work research in hospital settings. He has been part of MASWO since its inception. The next speaker is Martin Matthews. He works in dual settings, hospital, as well as child welfare. He holds a master's degree in social work from Rajagiri College of Social Sciences and is a registered social worker. Mr. Matthews has been working at Family and Children's Services of Waterloo Region as a full-time child protection worker for 20 years. In addition, he works as a medical social worker at Brantford General Hospital. Martin worked as a social worker at Kiwalik Regional Health and Social Services, Nunavut, and as a case manager at Niagara Health System. Our next speaker is Sdm Joseph. He's a clinical social worker employed at Mackenzie Health Hospital and Scarborough Health Network. His area of practice includes individual and family counseling, community resource counseling, crisis intervention, case management, advocacy, and discharge planning. He obtained his master's degree in social work from University of Toronto. Sdm also holds a master's degree in personal management from Indore University, India. In the early years of his career in Canada, he worked with the Griffin Center as a therapist and provided individual, family, and group counseling to children and their families with dual diagnosis. Sdm has held various leadership positions since he came to Canada. Sdm is one of the founding members of MASWO. He has been taken lead role in organizing various programs and charity events for our fraternity. And our next speaker for the day is Vena Lewis. Vena has been working as a social worker in various community and healthcare settings for the past 17 years. She's a registered social worker and currently working as a social worker at University Health Network, Toronto Western Hospital. Vena holds a bachelor degree in law and completed MSW from Sri Shankaracharya University of Sanskrit, Kerala. Vena completed IESW, International Educated Social Work Bridging Certification Program from Ryerson University in 2007. For over a decade, Vena has been working as an inpatient social worker at Toronto Western Hospital, Neurosurgery, Spine, and Brain Unit. Vena has received collaborative academic practice fellowship in neurosciences. She's also an adjunct lecturer of University of Toronto. I would like to welcome all the speakers for this knowledge sharing session. So let's kickstart the presentation. Over to you, Vena. Please go ahead.
Thanks, Praveen, for the introduction. Good evening, everyone. Welcome to this session of Introduction to Hospital Social Work. I will be talking about the qualification of social workers in hospital setting, what settings that they work, the skills, and also the role of social workers. That's a topic that I will be covering. Talking about the qualification of a hospital social worker. All social workers at hospital settings have a university degree, either an MSW or a BSW, and need to be registered with the College of Social Workers. They need to have the title of RSW. The settings where they work, next slide. Social work works as a part of interprofessional team in hospitals. They work mostly in the outpatient setting and in the inpatient settings. The outpatient settings are also called ambulatory care settings. What happens in outpatient setting is that it provides medical attention for patients who do not require an admission to the hospital. It could be a pre-admission or a post-admission. Social workers, what they do, they work with patients sometimes in person, sometimes it's over the phone, sometimes over various technological devices. And during this COVID time, we have seen a lot of technological devices being used. I have a list of outpatient clinics, just to give a little idea of what it is. It's divided into four, one being a specialty medical clinic, which dialysis clinic, HIV, sickle cell, complex medicine. There are many more. Then there is something called an outpatient care center, which are outpatient rehab setting, seniors clinic, day hospital. Then comes the primary care setting, which is where the family health team comes. Not all the family health teams are associated to hospital. However, some hospitals have a family health team. Mental health and addiction is another outpatient setting. One of the major roles, there are many roles, one of the roles is to minimize admission of these patients to the hospital and to follow up on any discharge plan. Inpatient, as Praveen introduced earlier, I work in an inpatient unit. Inpatient is where the patients are cared for whose condition needs a hospital admission. They are either acutely ill, critically ill. They are in the hospital. social workers work with them when they are in the hospital, admitted in the hospital, and they terminate the relationship when the patients are discharged. Upon discharge, there's no further professional relationship with the patient. Following, I have some areas listed here, which are the inpatient settings. This will help us to know what happens in the hospital inpatient. General internal medicine, that's where patients who have general medical conditions, which is categorized as non-specific. It could be simple from high blood pressure, high blood sugar, to very complex medical conditions. Patients are admitted for that reason. Surgical, being orthopedic, broken bones, ankle, hip, knee, neurosurgery, brain, spine, any conditions related to that, gender surgery, and there are many more. Then there are also called specialty clinics, which are labor and delivery, cardiology, stroke, palliative, neurology, to name some of them. Intensive care unit is where patients are when they are critically ill. What happens, most of the work are, given the patients are critically ill, a lot of the work are done with the families when they are in, or the collateral sources, when they are in intensive care unit. Rehabilitation centers and complex continuum care is another inpatient setting where social workers work. Emergency department, I have listed it with the inpatient setting. However, it's neither an inpatient setting nor an outpatient setting. It's a world of its own, and the role of social worker is quite unique in emergency department. It is attached to an inpatient setting. It's really hard to explain the skills of social workers. We have lots of skills. We use those skills every day. I have picked some of the skills which you use on a regular basis to explain the skill set that's needed for a hospital social worker. Being assessment, communication, critical thinking, therapeutic, teamwork, learning, emotional intelligence being some of them, which will be explained in the following slides. In the assessment, some of the key concepts are, as I say in the slide, assessments are a primary practice tool of social work profession and is a core social work competency. This is kind of bread and butter for social workers. It is a roadmap by which we work. Every referral that a social worker gets in a hospital, where you evaluate the patient, you do the assessment. It is an ongoing process. When we do an assessment, we get information from various sources, like listed in the slide. Keep in mind that some of these sources of collateral may require consent. Some of them falls under the circle of care. Next slide. I have a definition by Australian Association of Social Workers to say what is a psychosocial assessment. An assessment that considers the physical, psychological, and social aspects of the client and their situation. It seeks to understand how these factors impact one's overall function and well-being and to develop interventions. The little Venn diagram on the side shows about the biological factors, the social factors, the psychological factors, how it all plays a role in the health and mental health of the patient. I have a little case example where I could talk about how the framework of assessment is done. This itself is something could be going on for about 2 hours or more than that. I'm trying to do it in less than a minute. So we have a referral for a 59-year-old male with repeated admission due to seizure. This is the referral that a social worker getting. So if you're trying to go through this case and see what are the factors, what is a framework a social worker could use to identify the issues and help the patient. In here, what is the presenting problem? The presenting problem, the referral for social work, is a repeated admission. The patient has been coming to the hospital many times. Then we look at what is the predisposing factors. So what is it contributing? We see from the admission note that repeated admission due to seizures. Post-seizure, post-ictal, they come to the hospital. As a social worker, through the interview and through your collateral information collection, you try to find what are the stresses, also called precipitating factors. So you look to see what are the precipitating factors. This was a case that I had, and where I found this case had an issue. It was a medication compliance issue. trying to see further, like you see why is this happening? Why is this ongoing? Which is the perpetuating factor, and was able to find this patient misses some medication on a certain day. In this case example, it was on Sunday that this patient was not taking medication, and all the admissions were either on Tuesday or on, Monday or on Tuesday. Looking into, like as you go with assessment, you look to what is in favor of this patient, like what is it that you can do, which is a protective factor. You can educate the patient about the importance of taking medication, make reminders, try to arrange for services. In this case, we were able to arrange for support for the patient from the housing where he was. So that's an example that helps us to understand how a psychosocial assessment, how a case is dealt with. This is a simple case, complexities can occur. Moving on to the next skill, communication skill. This is like we communicate, we talk, this is how we work. Effective communication skills is very crucial for social work job. Being verbal, like how we communicate, like being clear, like your tone, your how you verbalize. Like we all have the habit of talking a little too fast. So like watching all those things, like being as clear as possible. Active listening being another skill. Communication is two-way. It's not about you talking, it's also about how you listen. You're watching your body language and anything that will make the patient feel that you are actively listening to the patient. Written and documentation. This is crucial, especially in a hospital healthcare setting. I was taught when I started the job, if you don't document, in principle, you did not do it. Whatever you document is what is the proof of what you did. Like if it's not there, it doesn't count as something work that you did. Another communication skill mostly like used in negotiation, advocacy, which all plays as the role of social worker. Critical thinking. What is critical thinking? This is where you're able to look into a person or their situation from an objective and a neutral standpoint without jumping into conclusions or assumptions. How you do this? Like you use your analytical skill, like you try to see what are the ins and outs, analyze the situation. You identify the needs, the strength, the weakness, what opportunities are there. Patient may be stating the facts, and social worker is the one who sheds lights on identifying the key concepts. Prioritizing. Caseload, it may be very high in a hospital, and it's a very fast-paced environment. We need to prioritize based on the client's needs and also on the organization expectations. Therapeutic skill. Social worker, any intervention of social worker, we use the therapeutic skills. A therapeutic intervention assists in improving the well-being of the patient. That's a goal. In that, counseling being the first one or the major one. So it is a tool that's used by the social workers, and it's not the only thing that we do. A lot of people ask, like you work in a hospital, you may be doing a lot of counseling. Yes, we do a lot of counseling, but that's not the only thing we do. We do a lot more than that. Therapeutic intervention. Therapy is more kind of a treatment based for the well-being of the patient, being a psychological, social, or emotional well-being. Comfort and guidance, especially in palliative care settings, dealing with grief, loss. We use a lot of our skill of comforting patients and providing guidance to them. Learning. This slide will be explained a little in detail later. However, I can guide you through. Medical conditions, the unit where you are working, knowing what happens to the patient, what are the conditions that commonly happens, and also knowing the terminology. I remember when I started the job, first day going in, I felt like I was hearing a foreign language there, uses lots of acronyms. So knowing some of those things are helpful. And learning those things, quick learning is a skill. New researches and advancements, provide educations and training, patient and family education about hospital process, illness, and impact of diseases. Teamwork, again, this will be explained later by Sajiman. Interprofessional collaboration and effective and efficient teamwork. Emotional intelligence. Much of a debate happened between whether this is a skill or an ability. Emotional intelligence is an ability. However, happens through practicing a lot of skills. Empathy. I am with a whole bunch of social workers. I don't have to say what empathy is. There's a reason why we all are here. We understand how patients feel. Self-awareness. Confront the social worker's prejudices and stereotypes. Self-awareness is an essential element to prepare one to encounter the patient's personal matter, their attitudes, and their thoughts. It is quite crucial in your practice. Being sensitive to patients, to the needs of patients and the family and their unique needs. Cultural differences all does play a role in here. Moving on to the next topic, which is the role of social workers. We divided it into 3 sections. 1, social worker's role in the well-being of the patient. Next one being the discharge planning and also the interprofessional collaboration. I will be talking about the well-being of patient and the later will be done by the next speakers. What is in the well-being of the patient? I explained about psychosocial assessment. Any referral that you get, you do a psychosocial assessment. So that is what helps you to work with the patient. Counseling support to individuals and families. As I said earlier, that's not the only thing we do, but we do a lot of that too. Therapeutic support to help the patients for their well-being, especially when dealing with grief, dealing with the impact of disease. We provide a lot of therapeutic support. Crisis intervention. Patients come with financial crisis, relationship crisis, emotional crisis, mental health crisis. As a social worker, you intervene in the case with the patient and develop a plan. Assist with coping strategies. A lot of people cope differently. Everybody cope differently, and the strategies that works for them are differently. You work with the patient to know what works best for the patient, and you help them to develop that and encourage them to use. Empowerment model is used. We provide information about community resources and also do a lot of resource matching and referral. With this, I will thank you so much for listening. I'll pass it on to Sajimon to talk further about the role of social worker in discharge planning and multidisciplinary team. Thank you.
Thanks, Praveen and Veena. Good evening, everyone. My name is Sajimon Joseph. In my presentation, I will examine social workers' role in discharge planning, how we work with the multidisciplinary team members, networking with the community agencies, and the challenges we face in our day-to-day work. So let's focus on what is discharge planning. When we talk about discharge planning, you also need to understand what is the new trend happening in the healthcare. Now, in some of the hospitals, social workers are not really, or the hospital, they don't want social workers to do discharge planning. In order to do that role, they are hiring just discharge planning in order to do that. But in other hospitals, they want social workers only do complex discharge planning. Complex means complex medical, social, and health. And then in other hospitals, they want the social worker to do an active discharge planning role. So when you look at Toronto or Ontario, 80% of the hospitals, they want social workers to be actively get involved in discharge planning process. Around 20% of the hospitals, they want social workers to do only complex discharge planning, and maybe another 10% of the hospital, they want the discharge planning has to be done only by the discharge planners. So I just want to give you what is happening in the hospital setting nowadays. So let's look at discharge planning. What is discharge planning? Discharge planning is one of the most valued functions of social work in an inpatient unit. Proper discharge planning requires input from multidisciplinary team members. So before I start talking about the multidisciplinary team members, I will focus a little bit more about discharge planning. What is discharge planning? When a patient comes to the hospital, in the discharge planning start as soon as they step in the emergency department. Most of the time, if patient has no acute medical reason to get admitted, they will be discharged from the emergency itself. In the only patient going to get admitted to our inpatient unit, they need active medical intervention and treatment. So when they come to our unit, then we need to really start working with them. So what we do, we identifying and preparing for patients' anticipated healthcare needs after they leave the hospital. Preparing patient and family to get to a safe living situation after acute hospitalization. And then providing supportive counseling and education to patient and family. So when we will look at it, if we can safely fulfill all the needs of our patient at home, we always look at sending them back home. That is our #1 discharge destination. What is going to happen? Seniors and frail elderly people whose care needs cannot be safely managed at home. Why? Due to lack of community and family resources, or due to the severity of their medical condition. So these type of people, we need to look at long-term care, rehab facilities, retirement homes, convalescent care homes, palliative care homes, group homes, shelters, and other housing options. It all depends on the patient's medical needs and then their functional decline and their support system. So when we look at it, all these places which I talked about where they can go, these places requires different type of application. For example, if a person is going to a nursing home, which we don't usually encourage from the hospital. So the nursing home application is done by LHIN, Local Health Integration Network. They are the only one completing a long-term care application. When we look at sending patients to rehab, retirement homes, convalescent care homes, palliative care homes, then the social workers, we play an active role to completing this application. Then you need to understand how we do the application. So there is called RM&R, Research, Matching, and Referrals. So this is an online application process which we try to complete it with the help of the other multidisciplinary team members and send it to different rehab facilities. Or if it's a retirement home, there is another level of application we need to do. So I just want to give you that example in order to make you to understand that whichever facility the patient is going, their different level of application process needs to be completed. I just want to focus a little bit more about the discharge planning and how we're going to get the referrals. So we don't need a referral technically from multidisciplinary team members. We can get involved, depends on a patient's need. But we usually get referrals from our multidisciplinary team members. So when we get a referral, what we do? We do a thorough psychosocial assessment. That is something Vena talked about, how to do a psychosocial assessment. Then we start discussing with the interdisciplinary team members about the patient care needs. Then we're going to discuss with the patient and the family. In order to start working with the patient, we always need verbal or written consent from them. So once we have that, then we start working with them. When we look at it, if the patient can be safely discharged home, then we will send them home. If the patient cannot be discharged home, if rehab is an option, we try to send them to rehab. If rehab is not an option, we look at maybe a retirement home. Then you need to understand difference between retirement home and a long-term care. That may need a lot of time to go through that. So I'm going to leave that for another level of presentation or discussion. So then we need to look at how we're going to get our community partners. We're going to refer to our community partners to providing services at home. We need to have regular update with our multidisciplinary team members, how we are doing this discharge planning, what is the progress we are able to make it. We need to organize family and case conferences, depends on the patient's needs. So we need to provide ongoing support that's very, very important to the patient and the family members during this discharge planning process. The most important thing we need to understand, or we need to ensure the patient legal and ethical principles. And we have to follow the confidentiality, client self-determination, respect, etc. And then advocacy. How are we going to do advocacy with the other community agencies, including LIN, and then our multidisciplinary team members. How are we going to educate our multidisciplinary team members about our patients and family care needs? So let's look at who are our multidisciplinary team members. So before I start talking about the multidisciplinary team members or team, let's read a definition about that will help you to understand better who they are. A multidisciplinary team is a group of healthcare workers who belongs to the different disciplines. Multidisciplinary teams convey many benefits to both the patient and the healthcare professional working on the team. These include, we need to include importance of outcomes and enhanced satisfaction for clients, and more efficient resources and enhanced job satisfaction for team members. So that is a simple way of looking at it. Who is this multidisciplinary team? So basically, these are the team members in the social workers work on a day-to-day basis. So I want to make it a little bit more clear to you. So where the social workers, when we work with the multidisciplinary team members, we work with the doctors, we work with the nurses, we work with the occupational therapists, physiotherapists, speech language pathologists, pharmacists. So these are, and then the LIN coordinator. They are also very important in case if a person needs to go to a long-term care, we need to work very closely with the LIN coordinator. So these are some of our multidisciplinary team members which we work on a day-to-day basis, and we try to educate them about our patients and families' needs. And then it's not only educating them, you need to get the feedback from them because they are also working very closely with the patient. For example, a physiotherapist working very closely with the patient in the day-to-day exercise program, and then they're going to give you feedback about how well they can walk, how well they can transfer from bed to a chair. So this is very important. You need to get the feedback from them in order for you to do a safe discharge planning. So let's look at who are our community partners. So our community partners are long-term care, retirement homes, supportive housing, seniors apartment, group homes, shelters, rehabilitation hospitals, complex continuing care hospital, palliative care unit, hospice, withdrawal management center, accessible transportation, home at last, locked house calls. So there are so many community partners we need to work on a day-to-day basis in order to safely discharge patient back to community. Community means back to home. And then in order to work with these community partners, this is the very important role we play, the role of advocacy. You try to get whatever the help and support for your patient and family in order to keep them safe at home so that they don't really coming back to the hospital. So it's very important you need to have that knowledge. Not only the knowledge, you need to know how to work with them and how to advocate for your patient. So this is very important, which Vena kind of mentioned about the role of advocacy, and this is something we need to do it on a day-to-day basis in order to sending our patient back to home or wherever they need. So I talked about the social workers' role in discharge planning, how we work with the multidisciplinary team members, how we work with the community partners. Now I'm going to look at what are our day-to-day challenges. So when we work with in the hospital settings, it is very important to understand that in one of the Vena's mentioned that you need to prioritize your cases, and because hospital is a very fast-paced environment. So when we look at our challenges, we can divide that into 3 categories. We can divide it that the systemic challenges, institutional challenges, and patient and family challenges. So let's focus on what is the systemic challenge. When you look at the systemic challenge, the most important thing you need to understand that we don't have enough resources in our community. Especially when you work with the seniors, they need a lot of help and support because they are already frail, they are already elderly, they have all the complex medical needs along with the physical deconditioning. So in order to safely support them home, they need a lot of resources. Do we have resources in our community? Unfortunately, no. So that is a major challenge the social workers come across on a day-to-day work. Then we need to look at our seniors. Our seniors, do they have enough money? Unfortunately not. If a person is collecting only their pension, they don't have enough money to meeting their day-to-day needs. So most of them end up in poverty. When they are poverty, they cannot really afford any extra care with any kind of price. So that is also a very major problem in our community and especially in our healthcare system. Let's look at what are the institutional challenges. When I say institution, I say hospital because in the people, those who want to work, we work in a hospital setting. The hospital, their focus is patient flow. They don't want keeping people if there is no need to keeping them in the system. In order to keeping them in the system, it's going to cost them a lot of money. So they want patient to get discharged very soon, very fast, and they will try to look at it and then try to pressure you why the patient is not leave the hospital, why you are still keeping them in the hospital. So there is a lot of pressure from the institution. And then the doctors, when they look at it, their only role is to make them medically stable. When a patient is medically stable, they call them ALC or they write an order that this patient is medically clear to go, the patient can go. Why the patient is not going? Because we cannot support them in the community. Why we cannot really support them in the community? Then it's all coming back to the social workers. So that is again a major challenge. So then we need to focus, what are the patient and family? What are the challenges they bring it to you? So they have the unrealistic expectation. As soon as they come to the hospital, their goal is to stay in the hospital as long as possible. So even though they are medically ready, they can leave, but always they think that, oh, they are not ready. Because when you look at it, these frail seniors, they don't feel that safe. And then when they are in the hospital setting, they are surrounded with the caregivers, they have a comfortable environment. When they are back home, they all are isolated. So they always want to stay in the hospital so that everything's are provided to them. So they have all this unrealistic expectation about how they want to be in order to get back home. And then we need to look at the disintegration of the family unit. Suppose that if we place one of the husband or the wife in a long-term care, the other one is going to be left alone. So this is a disintegration of the family unit. And then there are a lot of addiction and mental health issues among seniors. So a lot of seniors are addicted with alcohol. So they need addiction counseling. They may need detox programming. So these are also some of the challenges we face on a day-to-day life, on our day-to-day work. So even though I said all of this, I think that the hospital social work is a very noble profession. And I want to encourage every one of you, if you are interested, please apply. Don't scare about it. So even though we are talking about all these things, you think that, oh, they have knowledge. No, we got all this knowledge with so many years of work, and you all will get that. Once you get into the field, you will always get that knowledge. You will always get that skill. So I want you to apply for it. Keep on applying until you get the job. So with this, I want to say thank you for listening my presentation. And then if you have any questions, we will address that at the end of our presentation. Now I'm going to give it to Martin to talk more about the legislation piece in the social work area. Thanks again.
Thank you, Sajiman. Good evening, everyone. My name is Martin Matthews. My task here is to talk about the commonly referred legislation in medical social work.
Can I excuse for a minute? So all parties.
Social workers are often called upon to perform tasks that has legal and ethical roots. Social workers are covered under the Social Work and Social Services Act. Medical social workers is the same as other social workers. We have a RSW, major legislations in medical social work are Healthcare Consent Act, Predisposition Act, Personal Healthcare Information Protection Act, Child, Youth and Family Act, Vena Health.
Baby.
Next slide, please. Ontario Healthcare Consent Act.
Martin, 1 second, Martin. Sorry to interrupt you. Would you please mute so that everybody can listen properly? Thank you so much. Please go ahead.
Thank you. The healthcare professional's right to treat patients come from the patient's consent. That means before any medical treatment can begin, except under emergency condition, the patient or Sdm must give informed consent to that treatment. And then what is an informed consent? Informed consent means that a doctor must provide the patient or the patient's Sdm with all the information they need in order to make a decision about that treatment, which includes what the treatment is meant to do, the likely benefits of the treatment, the possible risks of the treatment, side effects of the treatment, options, if any, other than the treatment being proposed, what is likely to happen to the patient if the treatment is not received. The Act establishes rules for determining capacity of a patient. Then we need to kind of look at what's capacity. The Act defines mental capacity for treatment decision as the ability to understand information that is relevant to treatment decision and the ability to appreciate reasonably foreseeable consequences of making or not making that decision. It's very important that the patient understand the consequences of making or not making, or consenting or not consenting to that treatment. What recourse the healthcare provider has when the patient is incapable of providing consent. This gives the, this act gives the healthcare provider to look at other options when the patient is incapable of making a decision. Next slide, please. Substitute decision maker hierarchy in Ontario. I'll talk about that in a couple of slides after. What to do in an emergency situation, admission to care facility, home-time care, and the requirements. And the long-term care, the medical social workers don't do much in the admission. The assessments are done by Lynn, as Sajiman mentioned before. Rules about personal assistance service in care facilities. Just want to touch a brief scenario here about the capacity. I just say Mr. M was in a car accident, had multiple fractures, needs surgery to rectify the injuries. While at the hospital, he was able to comprehend and retain information provided and was able to communicate his decision to doctor regarding proposed surgery. In this case, he's deemed as capable of providing the consent. A lot of times when we are in emergency, in ICU or something, the patient come to the hospital and there is people with him, or then when the nurse or the social worker who ask him questions about what is going to be done, the other people will ask, why are you asking this person? I am here, he's injured, all right? But again, we have to make sure that, you know, he understands, he can comprehend, he can retain information and communicate that decision, whatever the decision is, then he's considered as capable. Say Mr. M, the condition is a bit more serious, had some head trauma, needs surgery to rectify his situation. While at the hospital, he was not able to comprehend and retain information shared and was not able to communicate his decision regarding proposed surgery to the doctor or whatever we are proposing. Social workers talking about what the next steps are. If he's not able to understand and communicate his decision, then he's deemed as incapable. In this situation, the decision making then going to the substitute decision maker. The substitute decision maker I'll talk about in the next slide. So then what's an emergency situation? Emergency situation, in the case of Mr. M in the second situation, when he's not capable of making decision and there is no substitute decision, say there is no substitute decision maker available in the hierarchy, then any delay in treatment would prolong Mr. Long's suffering, or delay would put Mr. M at risk of serious bodily harm. Then the doctor has to make a decision based on Mr. M's best interest. As long as there is no reason to believe Mr. M does not want that, in this case, the proposed surgery. So the doctor has to make a decision, it's kind of put the patient at risk if he wait to get consent from somebody else or waiting for someone to come and give consent. So then the doctor has to make a decision and proceed without a consent. So that's in an emergency situation. Sometimes, any treatment, we have to make a decision, we need to proceed with it. Like even in social work too, like if you are talking about something, if there is an emergency, then we need to take that decision. Next slide, please. Substitute Decisions Act 1992. Law that governs what may happen when someone is not mentally capable of making certain decisions. Deals with personal care decisions, deals with property. There is two kinds of power of attorney. You can have one for the personal care and one for property. Power of attorney for personal care. Power of attorney is a person, if a person is capable, he can appoint a person to look after his personal care needs in the event that he become incapable. So this is a decision a person make when he's capable of making decision in order to make decision when he's not capable of making decision. This act provides mechanism for dispute resolution. I mentioned in the previous slide, we have a hierarchy of substitute decision making that help us to kind of solve some problems. Say there is some disagreement with the family members about who's going to make the decision, then that substitute decision maker hierarchy gives us the option to decide which ranks first, and we can go through that rank. Also, if a person challenges the decision about the capacity, not capable of making a decision, he has the right to apply to the Consent and Capacity Board to do a review of that. And the last resort, if there is no substitute decision maker available for a patient, the last resort is the public guardian and trustee. Next slide, please. I just want to touch on the role of a substitute decision maker here because most people probably would like to know that. The substitute decision maker must make decision based on prior expressed wishes of the patient. Generally, the case, substitute decision makers are close friends or relatives, or they generally know the patient's wishes, beliefs, and values, so it helps them to make the decision for the patient. If the SDM does not know of a wish applicable in the situation, or it is impossible to follow the wish, the SDM must act in the patient's best interest. So the SDM has to ask a question: if the patient was capable of making that decision, what would have been his decision? What decision the patient would have made? So that's an important role the SDM has to play. He kind of ask that question, and that helps them to make that decision. Next slide, please. As I mentioned before, there is a SDM hierarchy. The first one is a guardian with authority to give or refuse consent to treatment. Generally, the guardian is appointed by court when somebody is deemed incapable. an attorney of personal care with the authority to give or refuse consent to treatment. Attorney doesn't mean it's a lawyer. It's when a person is capable of making decisions, he appoints another person to make decision on his behalf in the event he becomes incapable. A representative appointed by the Consent and Capacity Board. Again, you know, any family member or a friend can apply to the Consent and Capacity Board to be appointed as a representative to make decisions for the patient. In the event the person already appointed a power of attorney for him to make decisions for him, the Consent and Capacity Board won't appoint any representative. The next one on the rank is a spouse or a partner, and the next one is a child or parent. A parent who has only right of access, say the other ranking people on the list is not available, and if there is a child and there is a decision need to be made, then the person with only the right of access can make decision for that child. Then the sibling, a brother or a sister. Suppose there is a more than one sibling, like you have 3 or 4, then they have to come up with they have to agree on a decision, or they have to kind of agree who is going to make that decision. That's how it goes. Any other relative related by blood, marriage, or adoption, then again, like I mentioned before, none of the above mentioned SDMs are not available, or there is nobody for that patient, then the public guardian and trustee will become the substitute decision for maker for that person. Personal Health Information Protection Act 2004. This is known as the PHIPAA. PHIPAA is the privacy legislation specifically for the healthcare system. PHIPAA governs the manner in which personal health information may be collected, used, stored, disclosed within the healthcare sector. It is important that Vena mentioned before, when you get a consent, you can get the consent. If you don't document, you got the consent to collect or share or do whatever with that consent you have to document it. Otherwise, there is no consent. Accessing or sharing healthcare information without proper consent is illegal and is punishable. It's the same as in any other social work practice. You have to have, you have to use use it appropriately. For a reference, Ontario College of Social Workers and Social Service Workers has put out a document to guide our practice. Whenever you get a chance, please look at that. It's in our social work. There is a guide, that will help you to get more information about this. The next one is the Ontario Mental Health Act 1990. It regulates the administration of mental health care in Ontario. This is specifically important for social workers in psychiatric units and psychiatric hospitals. It deals with admission, treatment, and discharge of patients in mental health facilities. Besides providing assessment and therapeutic intervention, social workers work with patients in involuntary admissions, discharge planning, consent and capacity, financial capacity assessment, and crisis intervention. Although I put the slide up here, I'm not going to go into details of the Mental Health Act because MASWO is planning a specific presentation on mental health. So they will go into details when it comes. It will be coming soon, to my understanding. And some of you are probably thinking now I mentioned another act, in the beginning, the Children, Youth and Family Services Act. I'm not going to go into details on that act as well, because when the child welfare, during the child welfare presentation last month, they extensively went through the act. And medical social workers, when we work with our patients, as we often come across the protection concerns. So we need to know what the age of protection and specifically the duty to report. Those are things we need to know and we need to act on. So that concludes my presentation for now. If you have any questions, then we can try to answer that at the end. Now I'm going to pass it on to our next presenter, Joseph Kalath. Thank you.
Thank you, Martin. My name is Joseph Kalath Daniel, and today my brief presentation is on education and research in a hospital setting. In this presentation, I will be dealing specifically with continuing education in the hospital, teaching social work students, teaching other disciplines, and teaching patient and community. Continuing education. Continuing education means we are expected to be lifelong learners, and we are. In a hospital, where we are in a hospital or anywhere in any professional setting, we are expected to be learning as we go along and as we progress. And learn current trends in social work. When we speak about current trends in social work, if you remember the history of social work, we started with crisis intervention, social workers, then we went to social welfare setting, we went to poverty reduction, then came to social justice field, we went to liberation movement, anti-racism, anti-oppression, a whole lot of things. Things keep changing, the trend keep changing. And so we need to keep up to date with what is happening, otherwise we will be left behind. Then keep up to date with the new research and practice models. Why new research? Because unless we know what is happening in the field and proven by research, we might be doing a lot of work, but we don't know the effectiveness of it. We do not know if it is right. We do not know if we are following the best practice models. There will be, when we do research and find out what we are doing the right thing, then we can do more of it, or we can continue doing what we are doing that is right. Then learn new regulations and laws that affect social work practice. If you look at it, laws keep changing. As Martin was saying, there was Child and Family Services Act. There was Child and Family Services Act in the 60s, 70s, 80s, 90s, and now even the name is changed from Child and Family Services Act to Youth and Services Act. In the same way, Mental Health Act, Substitute Decisions Act, Advocacy Act. Some acts disappear totally. Now we do not even have an Advocacy Act. It was taken out in '96 with the Substitute Decisions Act. So we need to keep up to date with what is happening in the field. Then learn new and existing resources in the community. We have a lot of resources in the community. If we know, new ones keep coming up, especially with the pressure in hospital setting. The Toronto Central Lynn, if you look at it, they have come up with so many new programs and resources so that to keep people safely at home, especially seniors, how to keep them at home, how to provide support for them. And also, some of them change their names. We may not know what they are called now. Before this old, for example, the old St. Christopher House is no more called St. Christopher House. They are called something else like Neighborhood House. And some of them disappear. A lot of agencies disappear, new ones come, so we need to keep up to date with them. And also keep good relationship with them. If we build good relationship with them, what happens is that we can get the services faster, quicker. We may have a particular person whom we talk to often, and that person we might be able to access quickly. Then learn about community and social needs. So in the community, there are what needs are coming to us? How is the geography of the area that we work change? For example, in downtown Toronto, how has it changed in the last 5-10 years? So many new settlements, so many new condominiums, which changes the population mix. So we get a new kind of population, we get more pressures, as the population grows, you get more different types of illnesses, chronic illnesses, and different things. So we need to understand what is happening in the area that we work and practice. Then we have to learn about national and international issues. Example, refugee crisis, war. We should know if there is a war, are there more refugees coming into our area? And what are they coming with? Have they been in a war-torn area with a lot of PTSDs or a lot of trauma related to that? Are they coming with nothing? Do they have any kind of resources? Do they have families here? What kind of supports they have? If we know some of these things, we can prepare ourselves and go ahead and try to support them. Next, we are talking about student education. For student education, as we know, we are taking students from colleges and universities. So at least we need to have a minimum master's degree to teach them. Otherwise, some of the universities will not allow us to teach them. And we can teach the students in different ways. We can go to the university and teach them. We can we can conduct seminars, we can conduct workshops, both in the hospital and in the universities. And most of us, a lot of us choose to provide practicum experience to students in the hospital, where they come and stay with us. I mean, stay 3 or 4 days in the hospital, shadow us, and we teach them whatever we are doing. And then this will also help our profession, promote social work education and promote our own profession. If we do not teach, if we do not share our experience, who is going to do that? Then teaching other hospitals, other disciplines in the hospital. As Saji mentioned, we have a multidisciplinary team we work with. So basically we do spend a lot of time teaching other professionals. What do we teach them? We teach them about our social work role, our practice, ethics in social work priorities, promoting client self-determination and client independence. What are we? As social workers are supposed to be experts in a lot of things, especially we specialize in communication skills, interpersonal relationship skills, ethical practice. A lot of these things we are considered as experts. So we can use these in order to, we can use these skills that we have to teach other professionals. Then we do a lot of risk management in the hospital. How is that? How are we doing that? Give you an example. If a client comes to the emergency department or to the hospital and they leave without getting their needs met, they become angry, they become upset, and sometimes they are posing a big risk for themselves because they have not received their own their needed care. So the potential they can sue the hospital, potential they can sue you personally. And so as social workers, what we do, using our own skills and expertise, we provide good compassionate care with good communication. Therefore, we manage a lot of risk in that as social work as one of our roles. Then role of advocacy. We do a lot of advocacy for our clients. How do we get the treatment done for the patient the best way? Because as we know that there are a lot of things that goes along with illness for a patient. It may not be just the illness. There may be a lot of other things. There may be so much psychosocial issues patients come with. So we constantly advocate on their behalf, both with the hospital staff, care providers, and also in the community. As Sajiman mentioned in detail about how we had to work with the community partners to get the best resources, best treatment for our clients. Then coaching them about legal and ethical aspects of patient care. Coaching other disciplines, because we know a lot about legal and ethical aspects, they look towards us when there is an issue happens. Then involvement of family in treatment process. We as social workers usually involve the family. As we know, most of our systems theories and a lot of our theories are centered around patient focus plus the family focus. because patients do not recover or in an isolation. They need to have support from the family, support from friends, neighbors. A lot of family members are there, and some of them do not have family members. Then we involve the other friends and relatives or neighbors in providing care for this for this patient. And so we show role model to other care providers. How do we coordinate these services and help the patient? Then we also provide teaching for advanced directives, power of attorneys, how to obtain valid consent. In a lot of teaching hospitals, you get a lot of residents from other countries, a lot of observers from other countries, medical and nursing, social work, a lot of observers. And we try to teach them about Canadian healthcare system, the social support system in our country. And then in patient and community education. As social workers, we know at least a large percentage of our time is spent in patient education. When we do an assessment, when we intervene in their life, we teach them, we show them not only as a definition of social work, we help patients to help themselves. It's not enough that we just manage a crisis at that point and we help them to manage it at home and continue living a reasonably good life in the community by themselves without coming back to the hospital and getting help from us. Then often we meet with them, with the team and patients, to interpret its situation in the hospital, to clarify their concerns. For example, in family meetings, when a patient is given a difficult diagnosis, for example, a palliative care diagnosis, a cancer diagnosis, social workers are there to support them, to empower them, asking them to ask the doctors the right questions, the correct questions, clarifying the terminologies the doctors used for the patients, so that the patients feel comfortable to ask questions, feel understood, supported, and cared for. Then we prepare or help to prepare patient education materials like pamphlets, other education materials that are important for the patients, so that we can send it with them at home. Then the community, how do we educate the community? If you look at examples of social work in Toronto West End, for example, the mental health team puts up a lot of community education sessions, conferences, both in the hospital and outside. And sometimes social workers go out of the hospital to teach other community agencies. I used to go to community centers and provide education on various topics. And then sometimes we set up forums, sickle cell program, for example, conduct forums in the community as well as in the hospital for patients and family members. Then we can get done a lot of workshops for patients. Cancer care is very, very commonly put up a lot of supports for them. Next one, please. Yes, research. It's very important for our own personal growth and professional advancement. As I mentioned earlier, research really guides our practice and should guide our practice. If we are practicing without basis of research, what are we practicing? We do not even know if we are doing the right thing. So learn to do some research, and especially in a hospital setting, you get a lot of support. There are a lot of expertise to teach you how to do research, and there are a lot of resources available in the hospital. They support you through. You can present your research. You can present it in conferences in the hospital itself, or in big conferences internationally. And also you get support in publishing them. Any other? Next slide, please. So since I work in an emergency situation, most of my hospital work was in the emergency department of different hospitals. So I thought I will tell you a few scenarios that we commonly see in the emergency department. One, a homeless person cannot manage on the street as usual due to illness or situational crisis. I mean, it's a paradox. You can see why a homeless person cannot manage on the street, because many of us may not know homeless people have their own community network. Homeless people have their own network, their own resource supports on the street itself. Many of them may have a lot of friends, resources, people whom they know, where they sleep. They may have a little corner where they go and sleep. Sometimes due to illness, communicable diseases, due to a lot of other reasons, they may not be able to go back to the street corner where they came from. Then they come to the hospital. We need to manage that situation, because the hospital may not be the best place for them. They may not need a hospital admission, which would be the best, most suitable place for them. Elderly person cannot cope at home due to an unplanned event, including abuse. As we know, a lot of elderly people are single. They are either widowed or they have never been living in a community or in a family. So when they get old, they are alone. They have managed so far with the community supports or from family or friends or relatives. Now all of a sudden that is not there. Maybe if a neighbor whom they depended upon died, or a neighbor went on a vacation, or the community weather changed so much that the Meals on Wheels person cannot come to give them food, or the community PSW who used to come and visit, the PSW suddenly fell ill and the LIN could not send another person. So a lot of reasons why a person cannot cope in the community. So they come to the emergency department, not for an acutely ill scenario, but just cannot cope. And abuse situations. A lot of abuse happens in the community with the elderly. There is research available. If you look at it, almost one in every 8 elderly people who come to seek treatment have been abused some way or other. Primarily obvious ones are physical abuse, but hidden financial abuse in galore, so also emotional abuse. We may not know the emotional abuse and the financial abuse, and nowadays a lot of financial abuse we come across. And when we deal with the physical abuse, are we allowed to call the police or the authorities? Mind you, there is no specific act like the Child and Family Services Act where we are obligated to contact the Children's Aid Society. Here, there is no such act. If we go against the consent or without the consent of the elderly person and report it, we might be breaching confidentiality. We might be breaking the HIPAA law. So we need to be very, very careful about how we go about. We have to use our counseling skills, our therapeutic interventions, assessment skills, our support network in order to get the proper care for this person. Then sudden homelessness due to fire or unforeseen events. Some of you may know, last 2 or 3 years, you must have heard about so many fire hazards in downtown Toronto. I think last year or the previous year, one apartment buildings in Sherbourne City had to be evacuated totally, and even now some of them are still not gone back. And when a large event or issues happen like that, they come to the hospital and we need to deal with such mass casualty. Then an abused youth who would not go back home and has disabilities. Person might be kicked out of home because of abuse, children, parent or others abuse them and they are kicked out, or they have disabilities and they have been living on the street and sometimes their wheelchair broke, they cannot go back. What do we do? How do we get these resources for these youth? Then an abused person, man, woman, transgender, any person who cannot go back home because of the abuse. They cannot, the abuser might still be there. How effective is police intervention? We do not know. We hear over and over again, yes, police have taken the person out, but we do not know the person might be back before the abused person gets back home. So what do we do with those persons? How do we support them? How do we help them? Where can we send them? Some of them may not have ever seen a shelter, and the shelter might be very scary for them. And if there are children, what do we do with them? An abused woman or man or a transgender or abused person want to go back home, but the home may not be safe for them. It may be unsafe. How do we plan or do safety planning for them? It all takes time. Then financial struggles at the verge of losing everything. There are so many people who are struggling through. I mean, especially now with the COVID, it might be a big issue for a lot of people who are coming into the hospital setting. They have lost everything. They have no job. They have no money. The emergency funds, probably they haven't accessed, or some way or other they are not able to access. So a lot of those financial issues, we need to know what are the social safety network in Toronto, in Canada, in Ontario. Then addiction and mental health related issues. You will be surprised the kind of people who come into our emergency. A lot of new immigrants, a lot of people who have become addicted to and have mental health issues. As I mentioned earlier, a lot of people coming from war-torn areas, refugees, new immigrants, they have seen too much. They have been traumatized so much. So when they come here, they cannot cope with the new stresses that is imposed by the new immigration system here. So they get into addictions, drinking, alcohol, drugs. And once you are in it, they cannot come out. And major accidents, calamities, unexpected death. People come into the hospital and die, or sometimes you find in people who are at home all of a sudden found dead, a neighbor finds them, or a home care person goes in 3 days after according to their schedule and find the person dead inside the room. So there are a lot of trauma, unexpected things happen like that, and they come into the emergency, we have to deal with them. Depression, anxiety, suicidality. People who work with mental health, it may be very common for them. There are a lot of people who are suicidal and anxious. They come to the hospital. We have to do an assessment. We have to do crisis management. We have to do a risk assessment and see if the person need admission to the hospital or we don't need them. We can support them in the community with outpatient clinics. Then patient with no ID. This is one of the major issues we face in downtown area. We find a lot of people with no identification whatsoever. We do not know if they had them. Most of the time they are lost or stolen. I mean, people go into with a lot of expectation into a shelter. First thing they realize is that whatever they had is stolen. They have no IDs, they have no clothes to put on, their bag is gone, their wallet is gone, everything is gone. So we have perpetuated more problem, we have given more problems. So where do they go? They come back to the emergency department. How do we deal with them? How do we support them? Unclaimed body in the morgue. That's another big thing that we have to deal with. A lot of times we often get quite a few. You would be surprised the numbers of unclaimed body in the morgue. Social workers deal with mainly the unclaimed body in the morgue. There are proper procedures. Sometimes it takes weeks, months. I had a case which took about 5 months before we could get that body claimed by or properly buried or properly sent to for burial. So it's a big job, and sometimes we have to deal with those issues. Then we also have patients who are lost, wandering, who are not able to provide information. I had a patient who came all the way from, we worked with that person for the whole week, a whole day. We could not find where this person come from, elderly person. Finally, we realized the person walked all the way from north of Richmond Hill, walked all the way down to Toronto, took 2.5 days, did not eat for 2.5 days, and reached there exhausted. Somebody found him and brought him to the emergency department. And we go through the police, we go through sometimes every resources we can think of, call them, and try to figure out where this comes from. The next slide, please. Okay, I think I end my presentation here. Thank you so much for listening to me, and I'll be here to answer if you have any questions. And thanks again.
Thank you, sir. Thank you all the presenters for sharing your expertise. Now we came to the question and answer session. So, and for your reference, so if you like to know more about consent and capacity or applicable legislation, so you can log on to the website and you can see more information on this website. So there are some of the questions which I have already collected from participants. So let's go through them. So let's go through the first question. This question is based on a scenario as described on the slide. A refugee single mother with 2 children below 10 years, recently diagnosed with 3rd stage of cancer. She is the only earning member and no other social support available. How will you support this individual? What are the resources to be considered while preparing a care plan for this patient? Vena, could you please answer this question?
Yeah, okay. So we see that this patient, you know what it is, like we have some information about the patient, as I said earlier, like psychosocial assessment, hopefully will give us like more information based on what I have, what support for this individual. This patient, as we see, is a refugee single mother. We assume that it is an IFH patient, the Interim Federal Health, which is a federal program for healthcare, whereas like every other residents have a provincial program, which is an OHIP, which is the OHIP. So in this, like looking at the medical situation, the cancer treatment, it is not something which happens like for an OHIP patient. It needs approval. It is something that the doctors take care of that. It does need approval for chemo and radiation or any other treatment that this patient may need. Another thing that we look at is if this patient needs to go home, we need to arrange for some services at home. Being an IFH patient, we will not be able to receive the LIN support services. So we look at different agencies which are approved funding for IFH. Some of them name being St. Elizabeth, Blue Cross. However, we all often come across funding issues with these agencies. We look at informal support, like whether there's a church involved or there is an ethnic community involved. We look at those ones, we advocate, we talk to them, we try to mobilize resources for them, and we negotiate for the patient. Another area will be the financial. So it says here that she was the only earning member of the family. Being somebody who's a refugee, they are eligible to receive Ontario work. So helping the patient to go through that process and obtain the welfare, the Ontario works that's available for them. One other thing that says is they have 2 children below the age of 10 years. So the service mobilization, connecting them to children's aid for service mobilization. It's a situation where they need a little bit more service to help them. So connecting those and on any other agencies that can provide a situation. Again, it is stage 3 cancer, unknown about what's the prognosis of it. If it's a prognosis not very good, it's not looking good. Are we looking at a placement for this patient, like a palliative placement? In that case, what do we do with children? How do we help them place? So those are those are some of the factors that we look at when how we support the patient and to make a care plan. For sure, as we go to the case, there will be much more, but I kind of touch base on what is the most prominent things that we will be looking at.
Thank you, Vena. So let's go to the question number 2. This is another scenario as described on slide. A young homeless man lands up in emergency, later diagnosed to have chronic illness. When ready, he's not willing to get discharged from the hospital because he's afraid and that he will not get the same care once is out of the hospital. What is the social worker's approach to this patient? Sajimon, could you please answer this question?
Okay. So when you look at this question, so number one, he's a homeless man. And then when Joseph was talking about when you work in an emergency department, you're getting a lot of people, those who are from the street. Now, the problem with this person is that he has a chronic illness. So sometimes this chronic illness may need ongoing treatment. So we need to look at that, where this man could get ongoing treatment. So either he may need to come back to the hospital for the ongoing treatment, or can be able to find a specific shelter where he could get the attention of a nurse who can also look at his chronic illness. For example, he's a diabetic. If he's a diabetic person, his blood sugar has to be monitored on a regular basis, daily basis. So the nurse could, look at his blood sugar and then probably help him with providing the medication. Then the diet is also very important. And then if we able to find him a treatment shelter, they could also help him with the diet and all that. So when you look at it, why this person is not willing to go back to their shelter, because they are afraid, because their safety net, what they were having before, is not able to provide that level of care for him. So that's the reason. So as a social worker, what we do, we try to mobilize as much resources for this person. Even though he's a homeless person, he can also get support through LIN, Local Health Integration Network. They provide a wide range of services even for homeless person. So the only thing the LIN need is an address where they can provide these services. So as I mentioned before, if we can find there are some treatment shelters in Toronto. There are only a couple of them, and the social workers know who are the treatment shelters, and then a lot of the time we could probably find an accommodation for this man. Even though he's going to a regular shelter too, we can pool all the resources and send it to a regular shelter for him. Our role is to give him all the safety net we can provide, assure him about the services he can get wherever he goes. And then when a person is discharged from the hospital, we don't do an ongoing connection or planning with them. But there are other agencies, they can do that. LIN could do that. And then there are a lot of other community agencies which we could connect with him, and they could also do a case management for this patient. So these could be some of the social work approach we are going to do with this man.
Thank you, Sajimon. So I have received more questions, so let's go through them one by one. So please explain the role of Office of the Public Guardian and Trustee, and when does power of attorney comes into effect. Martin, could you please answer this question?
Actually, Vena is going to touch the first one.
Right, okay.
Yeah, we had a discussion. Well, so it is a very broad subject about the OPGT office. The website that was provided earlier, if you go through it, you will be able to get a lot of information about that. However, what is social worker's role with this public guardian and trustee is something that we can, again, quickly touch base. When it comes to a healthcare decision, that if there is a patient, like to protect a mentally incapable person, that there is a role for public guardian and trustee. So if there is a treatment decision to be made for a patient who was found incapable, then they try to see all the SDMs, and if there's no SDMs available, then it goes to the public guardian and trustee for a treatment decision. And so is for the placement too. If somebody is suggested recommended for nursing home placement, an evaluation is done and it found the patient to be not capable, then find that there is no SDMs available, then a public guardian and trustee will do the final paperwork to get this person to a nursing home. Another area of public guardian and trustee where social workers work is with the financial, PGT for finances. So if there's a concern of capacity in dealing with finances, then the hospital will call external assessors to assess the situation. They are people who have formal training and have a designation as capacity assessors. So we call them, they do the capacity assessment, and they find them not capable. Again, as a similar situation before, there's no Sdm available, then the public guardian and trustee will take their financial management of their finances. So that will be the person who's managing finances, and then will be providing the person with a little bit of money allowance every day. Also, public guardian and trustee gets involved sometimes after death, if there is for the funeral expense, to see whether there's money left, if there are any finances available, they get involved as well. Another unit, another public guardian and trustee area where social workers get involved is public guardian and trustee investigators unit, which is like a lot of explanation needed. I would refer it to the website, which is very clear, the explanation of what is a public guardian and trustee investigator can do for patients.
Thank you, Vena.
You're welcome.
And
the next question is, when does power of attorney comes into effect? In my presentation, I mentioned that the power of attorney is a person appoint when he's capable of making decisions. So it actually kicks in when the person is incapable of making decisions. So that's when the power of attorney kicks into effect. Like if the person is deemed incapable or incapacitated, then there is decision needs to be made. That's when the power of attorney kicks in.
okay, thank you, Martin. So I'm skipping some of these questions because we are running out of time. So I will close this presentation and we'll go back to the live question for a few minutes. Then I will wind up this session. All right, so I'd like to hear from the participants. Any questions? So I know we received a lot of questions. We'll prepare and we'll email you shortly. So move on. So it's 8:35. So okay, so any questions? Are we good to go? All right, okay. So on behalf of MASWO, I would like to thank you, each one of you, for your active participation today. MASWO is a professional organization and our goal is to support each other and our community. We'll be having our next session is on social work in mental health setting on next month. For more information, including the upcoming programs, please visit our website, maswocanada.ca. And you can also email maswocanada@gmail.com if you have any questions. Thank you all. Thank you for joining us today.